with which we move to the last presentation. Dr. Manisha Agarwal will be talking about endogenous endophthalmitis, which mimics infectious uveitis often. Dr. Manisha is from Dr. Sharaf's Charity Hospital. He is a vitreoretina and uvea consultant.
So a very good afternoon to all of you, and thank you, Dr. Biswas, for making me a part of this wonderful IC. Endogenous endophthalmitis, don't miss it. So I took a while to understand what exactly JB sir wanted me to speak on. So I thought the best would be to share the experience of dealing with endogenous endophthalmitis with all of you by sharing 2 clinical cases which we managed in our clinic. So this was a young 18-year-old boy from Bihar presenting with gradual painless diminution of vision in the left eye for last 6 months and treated with off and on oral steroids. There was absolutely no significant systemic or contact history, and the child was from a low socioeconomic status. The right eye fundus was absolutely normal and with a vision of 6.6, while the left eye fundus apparently showed subretinal fluid in the macular area extending till the arcade, and you had some kind of a yellowish subretinal lesion, which was again very extensive, and it also was accompanied with an hyperemic optic nerve head and a huge pocket of subretinal fluid. When we did an OCT, it showed thickening of the layers of the retina, that it was also involved, and it was just not a subretinal lesion. And this is how it appeared on doing a fundus fluorescein angiography, where we had mottled areas of increased hyperfluorescence within the lesion with diffuse leakage in the late phase, along with a hot disk. So we were quite sure that we were in fact dealing with an inflammatory pathology. We wanted to be sure that we are not, dealing with any kind of a masquerade, and we went ahead and did an ultrasound, which showed a circumscribed lesion which was quite large over the posterior pole, high surface reflectivity with a homogeneous low to moderate internal reflectivity, and with a pocket of subretinal fluid. So the provisional diagnosis, keeping a young boy in mind, we thought we were dealing with subretinal abscess secondary to tuberculosis, which apparently is the most common. And a possibility of other chronic infections also was kept in mind, such as a fungal infection and a lymphoproliferative disorder in this particular age group. So the patient underwent baseline investigations, where to my surprise, the Mantux was a 0, which you do not expect in a young child again. There was a raised ESR, which was suggestive of a chronic infection, and Mantoux 0 somewhere conveyed that probably the child was immunocompromised. Chest CT was normal. So we then sent the child to a pediatrician for evaluation, and the history that came out from systemic evaluation was that the child had not been vaccinated with BCG. He was having the slow growth percentile. The child was mentally subnormal. He had some skin infection. The HIV testing, of course, was negative, and the clearance was taken to start this child on systemic steroids because it was involving the macular area. So I was not very sure with what we were dealing with, so I went ahead and I did a vitreous biopsy. And this is something we should really opt for when we are lost with our diagnosis. So you see that a vitreous sample was taken overlying this particular lesion in the macular area. The gram staining came out to be negative. There was no acid-fast bacilli which was isolated. The PCR was negative again for MTB. The culture was awaited, and the treatment, of course, was started with IVMP, followed by oral steroids because it was involving the macular area. After IVMP and after 3 days, the patient looked something like this. Now, the patient started complaining of cough with expectoration, and the sputum was sent for acid-fast bacilli. It did come out positive, but it just showed a single acid-fast bacilli. And the physician was not really ready to start ATT because they were not convinced whether it was a contamination or whether it really suggested an active TB infection. So we started him on oral fluoxetine because this child was from Bihar and was now eager to go back. So we started him on ofloxacin, keeping in mind that it could probably have a role like a second line ATT, and also the child was put on oral steroids. Now the vitreous biopsy, which we had sent, started showing some amount of growth, and it was this creamy white growth which started coming out on the media. Gram-positive filamentous bacilli, they started growing. And this was finally diagnosed to be a nocardia species. The acid fast staining, the second time when it was repeated, it was negative. The MRI brain was done to rule out intracranial nocardiosis, which again is a very important thing to be done. And the patient was started on sulfamethoxazole and trimethoprim combination, and the oral steroids were continued. After 2 months, the child started responding on this treatment, and you see that there is a beautiful regression of the entire subretinal fluid. So, when we reviewed the literature, we realized that this is a rare entity, most commonly affecting the choroid, as the spread of this infection is hematogenous. The posterior pole is most commonly affected, as the choroid is thicker with more dense capillaries at the posterior pole. And the intracranial involvement is very common, and it's commonly confused with tuberculosis or a fungal infection. So, this was indeed a very big learning for all of us, where we had a very unusual type of organism which was causing an endogenous endophthalmitis in this young child, which we had not really expected. So, your mind always has to be open that you may be actually dealing with some kind of an underlying infection. Now, let me present another case, which is the other side of the coin. So, this is a 60 years old male patient presenting with gradual painless progressive diminution of vision in the right eye for last 2 months. There was a history of hypertension, diabetes, CAD, COVID treated with steroids in the past, and diagnosed as fungal endogenous endophthalmitis and treated with pars plana vitrectomy along with oral and intravitreal voriconazole elsewhere. So, this patient apparently was carrying these photographs with him, where the right eye apparently had the subretinal yellowish exudation, which was diagnosed as an endogenous endophthalmitis, keeping in mind that the patient had a history of COVID and was on long term oral steroids. The left eye apparently was quite normal. And the microbiology and cytological samples showed that there were no fungal elements, lymphoid cells with irregular nuclei apparently were seen. So this is how the patient presented to us. The vision was 6/9 N10 in the right eye. You have this extensive lesion, which again is very typical if we know the diagnosis. It's like a spot diagnosis. And this is how the left eye was. This is the right eye OCT, where you see this huge bump in the area where that yellowish lesion was present. And you also appreciate the ragged appearance of the RP with some amount of deposit under the RP. We also had a similar kind of bump even in the left eye, right in the subfoveal area. So here we are dealing with a patient diagnosed as endogenous endophthalmitis, query fungal, secondary to the history that the patient gave, but came out to be a primary vitreoretinal lymphoma. And we did go ahead and did a revitrectomy for this patient with a subretinal biopsy, because already there was a diagnosis that had been made for this patient. So here we have, I've gone ahead, I've made a small opening at the edge of this particular lesion. And finally, this exudative material was taken out from the subretinal space. I think the video is not working, and it was subjected again to the cytology and to the other investigations. Now, on H&E stain, it showed large and small lymphoid cells in a background of necrotic cells. The patient was suggested to undergo a mid-88 to confirm a PVRL. A PET scan and MRI brain was done, which was again normal for this particular patient. The patient did undergo multiple intravitreal injections of methotrexate, which were biweekly started. And this is the timeline of the patient, where you find that the patient has responded beautifully to the intravitreal methotrexate injections, which were given in the right eye. And this is the left eye, where again we find that the patient has really responded. We also subjected the aqueous humor sample to IL-10 and IL-6. And apparently, after having undergone the treatment, the IL-10 was not detected, which showed that the patient had responded beautifully to the treatment. So I would just conclude my talk by saying that endophthalmitis, even without a recent history of surgery or trauma, please suspect endogenous endophthalmitis. A detailed history to locate the foci of infection is extremely important. More posterior segment signs are apparently present when you are dealing with a patient of endogenous endophthalmitis. A vitreous sample with blood and urine samples is extremely important again to locate the foci of infection. And always remember to rule out any underlying masquerade which can probably be misdiagnosed as an endogenous endophthalmitis, like in my second case, because of the strong history of COVID and being on long term steroids.